You ready? Lauren, you ready?
Public Services on page 433 of your binders. I'll turn it over to Tim.
Good morning, Commissioners.
Morning, Tim.
This is day 2 of Public Services. I'm going to touch Health and Human Services today. So today we'll talk about some community programs that are tied to public services. We'll have presentations on Comcare, the Developmental Disability Organization, Department on Aging, and the Health Department. I think I failed to introduce folks that were here last Friday, so today I'm going to make sure that I do. I've got Dee Niswonger, Annette Graham, Adrienne Byrne, and Joan Tammany here all to support.
The heavy hitters.
All of the answers. Beginning on page 433, we have the community service community programs. We fund 2 different organizations, the Nonprofit Chamber of Service and the Child Advocacy Center. The Nonprofit Chamber of Service, we've had a relationship with them for a number of years now. They were initiated, if you recall, to help support the organizations that Sedgwick County relies on across human services and in corrections. Particularly, Sedgwick County relies on contractual relationships with a number of nonprofit organizations to help us deliver services in the community. If we didn't have that help, we would probably have another 400 or 500 employees working for us right now to get the services delivered that the community needs. The Nonprofit Chamber is designed to help those organizations be more successful, and they do that through a number of different trainings that they offer. Last year they trained over 600 individuals, and they've got 129 different member organizations. And then the Child Advocacy Center is an organization that is designed really to help children who are victims of some of the worst things that can happen to children only have to tell their story once. And so it's a multidisciplinary organization, and it focuses on advocacy, therapy, case coordination, and then support of both the children and the families that are victimized. In 2018, they served 2,370 abused or neglected children and also helped 1,125 caregivers. And so that's a relationship that the county has had for a long time as well. The funding request for those 2 community programs is flat from prior years, $220,000. And I'd be happy to answer any questions if you have any about those 2.
We'll take questions.
Okay. Beginning on page 437, we'll talk about Comcare. Their mission is to help people with mental health and substance use needs to improve the quality of their lives. We're going to talk about 5 different programs. We'll talk about admin and operations, and within that there are some homeless services that are delivered in the health home organization as well. Talk about adult services, crisis services, children's services, and then medical. The strategic results that Comcare has been working towards include doing at least 3 presentations a month, and in 2018 you can see that they exceeded that greatly, delivered 97 different presentations, touched almost 2,500 individuals there. A number of those presentations are going to be that mental health first aid training that we've talked about a number of times now. It helps community members understand how to talk to their friends or loved ones that may be in need of service and how to connect them with services. A goal was also to increase by 25% the number of children who experience a severe emotional disturbance receive rehabilitation services through Comcare. So it's a higher level of service that usually includes case management. And we've now, in 2018, they saw 600 more youth than they saw in 2017. So that's a great improvement. And a big part of that help comes through that school pilot program, because we're seeing kids sooner and kids that we may not have seen just because of the difficulty that some families experience in getting their children to services. And by having staff in schools, we're able to catch those kids sooner and help them to a greater degree.
Are we in Southeast?
Yes, we are.
Yeah.
And then lastly, we wanted to see an increase in the number of law enforcement participations that we do, and we worked 1,400 different times with law enforcement. And that number is down just slightly, but we partner a great deal with law enforcement in this community. So the administration and operations budget is both property tax and non-property tax, and it does all of the support things that you would think that you need to do for a large organization: finance, HR, facilities and operations. There are some examples of the work that they've done. They've collected over $19 million, processed 140,000 electronic claims, managed a huge number of contracts, and a great number of medical records requests. Also included in administration and operations are a couple of homelessness programs. Shelter Plus Care is a program that is designed to target a specific population, so it's individuals that are experiencing mental illness, substance use disorder, or HIV/AIDS related illness. And so there are 3 referring partner organizations: Comcare, Miracles, and the University of Kansas School of Medicine. And they served 265 individuals in 2018, including in that number 83 new vouchers. There's 112 vouchers total for that program. And the goal is to connect individuals that have some type of a barrier that causes their homelessness to housing and services, and then the goal is that those services will help them maintain housing and ultimately move folks from that level of housing into a different type of housing. And so we had a number of positive exits in 2018 as well. And then Housing First is a partnership that we have with the City of Wichita. It's an outgrowth of the Task Force to End Chronic Homelessness, and it's been in place since about 2009 or 10. And we share the cost. The Sedgwick County and the City of Wichita share the cost for 64 housing units that are scattered across Sedgwick County. We served 83 individuals in 2018, including 22 new program participants. And this program is designed to take individuals that are experiencing chronic homelessness from the streets directly into housing, and then follow that up with case management to help overcome those barriers that led them to homelessness. And then the case management is provided by the partner agency that refers them. So that's a very small staff that makes sure that we house those individuals. Any questions about admin operations?
Let me go back to the schools. That's a grant from the state that was set up specifically as a pilot program. Do you know what came out of the legislature last year? Are they going to continue that?
They funded the program for an additional year, and they did not increase our service dollars, but they did keep them level.
Okay. Was there any discussion at the legislature about expanding it to other school districts in Sedgwick County?
Not yet. Yes. Come on, Joe.
There was extensive conversation about expansion to 75% of the state. Where it got hung up is they couldn't figure out the financing of who would pay, who they would route the money through, and so it got held up, and so they stayed the same this year with the goal of expanding next year.
Okay. Next year, do we need to lobby to try and get it expanded through Sedgwick County?
No, I think there's lots of support for it. Truly was just they just didn't know how to weigh it based on size and how to get it paid. So the funding is for the uninsured and the underinsured. We generate revenue to pay for the positions. So we'll continue to work with some of the schools.
But in Sedgwick County, we have a way that they can pay us, and
right.
We can control it. So.
And the other thing is the schools through the school finance have additional funds too. So we're approaching the schools that have a desire to have us in them and seeing if they can use some of that new discretionary funding for these positions as well.
Good. All right. We'll keep that in mind next year because we do have a way of doing it here in Sedgwick County, and we've already demonstrated we can do it. So I'd love to see us at least expand it in Sedgwick County because that's what we represent. Thanks.
The not yet was about the funding.
Is there a breakdown? Is there a breakdown of the dollars for each of these different programs somewhere?
It's in your budget book, starting on page 435.
37.
431 will break it down like by the overview and then each.
And I've also got some slides later on that have it broken down a couple of different ways as well.
I mean the housing programs. You have the Shelter Plus, Housing First. Are those broken down?
They may not be broken down specifically in that budget. There's two different funding sources. I can break them down for you and send them to you.
Are these state or federal grants, or?
The Shelter Plus Care is a federal grant, and the Housing First is a county mill levy money.
The Housing First is? Okay.
Mm-hmm.
I see that.
Commissioner, Housing First is on page 446, and Shelter Plus is on 448.
Thank you.
Okay.
Mm-hmm.
I don't see any other questions.
Okay, in our adult services area, we'll start with addiction treatment services. That's a program that is designed to help individuals that are struggling with alcohol or other drug use. 2018, we served 1,383 different adults. The services are designed to help initiate and maintain sobriety, and the services include individual and group therapy, some medication management, so Medicaid-assisted treatment, and those are staff that deliver that along with community partners, and we deliver it in office and in the community through municipal and district drug court programs. Center City is our homeless program. It is designed to deliver services to individuals who are experiencing mental illness and homelessness, and primarily they're doing that through outreach and treatment. The biggest goal is to get folks from that outreach status into treatment. There's a number of different reasons why people may be homeless. A great deal of that may be untreated mental illness, and so the primary goal is to get folks from untreated status into treatment. They outreached 415 folks last year. They were able to deliver treatment to 353 individuals. And again, we've got case management services, we've got therapy and medication management services for those individuals. And that service happens primarily, if not in the community, at United Methodist Open Door. We co-locate those staff at that location. Our Community Support Services program is a program that is designed to treat individuals that have that are experiencing the most severe symptoms. They have met the criteria for a designation of a severe and persistent mental illness, and they need additional support to maintain in the community. These services are designed to keep them out of a higher level of care, primarily hospitalization. And so we've got a number of different programs that are designed to help them stay out of that most restrictive level of care. We delivered service to 1,319 adults, and that represents almost 21,000 encounters with individuals. Those services are provided both by Comcare staff and by partners that we contract with. In addition to the therapy and case management services, we also do supported employment and supported education for individuals in that program. Our outpatient services program is a high-volume specialty medical clinic, served 5,700 individuals, a total of 20,000 visits, and it's group and individual therapy for adults that are ages 18 and older. Folks that need some type of service to help them maintain employment, education, all the things that everyone would like to do. We've got services to help them to be able to do that. Our crisis services may be the services most familiar to you. We've got services available, emergency mental health services available on a 24-hour basis, 7 days a week, throughout the course of the year. In 2018, we delivered 13,428 face-to-face crisis services. We admitted almost 2,500 individuals to the Community Crisis Center, did over 2,500 assessments through intake, and those may be in person, they may be by televideo to an emergency room or a law enforcement, the backseat of a law enforcement's car. We do a lot of different outreach, handled almost 63,000 direct service calls with our crisis program. And again, we deliver that with internal staff by telephone, televideo, and out in the community. And you're going to see a decision package request related to additional community-based services. The Community Crisis Center in 2018 had 930 crisis observation bed guests, 235 crisis stabilization unit participants. The sobering unit saw 341 individuals. That's going to be a duplicated count. Most of these counts may be duplicated. Individuals coming back for services multiple times. Detox, 1,167 services, and then children's respite bed, 39. So we have an arrangement with the children's home where they reserve 2 beds for it. We pay them to reserve 2 beds for us. And then when it's appropriate for that level of care as an alternative to child being at home, but rather than sending them to the state hospital, they'll go to the children's home, and then we will send staff there, and we will staff that child for that stay while they're at the children's home. And we help 39 kids that way.
I have a question real quick. So out of the 930 people that were in those beds, do we have a number as to how many people were not able to receive services because we weren't able to handle?
I don't know that we declined services.
We haven't. So what would be, how do we determine that 8 to 12 week wait for someone? Is that where they would go?
That would be detox.
That's detox.
Okay. So is there any way to know what the unmet need is?
SAC might be able to help us define that for substance use. We can follow up with
Okay. That would be good to know. How many people are in our community that need our help but can't get it because the services aren't there?
We'll talk to SAC about that.
Okay.
Any other questions about those crisis numbers? Okay. Included in crisis services is our SCOPE program, or Sedgwick County Offender Assessment Program. This is a program that was started as a response to an alternative to jail. When we were about to expand the jail, add another pod, this was one of the programs that was implemented. We served 789 individuals last year, and the goal there is to deal with the mental health issues that may be causing or exacerbating their interaction with the law enforcement system. And so we've got case managers that work with individuals to make sure that they get to court appointments that they need to, so that they don't cycle through the system just because they can't make it to appointments. We deliver individual therapy to these individuals, and we work with them to make sure that they get medication if that's appropriate for them as well. Our children's program serves children up to the age of 21 with a severe emotional disturbance and are at risk of hospitalization. We do that through medication management, therapy, and case management services. We served 3,117 children in 2018, and we served 45 at-risk kids at our therapeutic preschool, the Proud of Me program, that helps children that maybe have been kicked out of every daycare that they've been to or every preschool that they've been to. We help get them ready for school. We have a tremendous track record of success taking kids that aren't able to maintain in a preschool setting, and they're successful in kindergarten and beyond. And so that's a really significant program. Doesn't serve a lot of kids, but it's a high intensity program, and it makes a big difference for those kids.
So refresh my memory, what services are available for children who are of school age?
They can receive individual therapy, they can receive medication management and case management services, and depending on the level of severity, if they're eligible for the waiver, there are wraparound services and some case planning services that go with that as well.
And that's all done at Waterman and
The-
Broadway?
The bulk of it is done there. Some of it is done in the schools. You know, we're going to do case management with kids in the schools. We're going to do therapy with kids in the schools. But the bulk of it and the med management happens there at Water, except for when our staff go to JDF, because we partner with kids at JDF as well. So we do the med management there. And Joan's right. Most of the case management happens actually in the community. So it may be at their home. It may be taking kids to experience things that other kids do, but helping them manage their symptoms so that they can do it more successfully. Community outings, that sort of thing as well.
Where are we at on the request from KVC?
It's pending, waiting, I think, some direction from the commission.
I have one more commissioner to talk to.
Okay. Are we going to put it on an agenda sometime?
If that other, yes, maybe. I mean, depending on what this other commissioner will tell me.
Okay.
We are split. There is not consensus on the commission on what to do with that.
Okay.
I talked a little before about medical services. We've got a large medical staff. We might be the largest behavioral health medical staff in the community. We've got 7 physicians. We've got close to a dozen nurse practitioners, and so we are a very large, high volume medical clinic, and we serve adults, children, and anyone that's in need. Did over 7,000 individuals, 22,000 appointments, and again, we're a high volume specialized clinic for behavioral health services. We have one of the few licensed child psychologists in the community, and we deliver services through televideo and in person.
Wait, back up one. That first bullet says that we provide medication-assisted treatment for persons battling opioid addiction. Opioid is not as great a problem as methamphetamines. Do we have something that's targeted towards methamphetamines?
Joan's going to correct me if I'm wrong, because she's really good at that, but there, from my understanding, there is not a medication treatment for methamphetamine addiction like there is for opioids. There is a specific medical protocol and specific medications that are designed to help overcome opioid addictions. That same level of care and drug doesn't exist for methamphetamines.
Is that methadone? What is that? What's methadone?
We don't do methadone.
We don't do methadone. The new drug is called buprenorphine. There is a methadone clinic in town. That is, I think, a previous type of treatment. There are new medications, and we have more than one physician that's trained to deliver buprenorphine treatment. You have to have a very limited case, so you have to be extensive training and a limited caseload to be able to do that type of prescribing.
I guess my concern would be if it's a limited caseload or limited capability. The DA has come in and talked to us about 11% of all people arrested have methamphetamines on them. And that's at the time they're arrested. They either haven't ingested it yet or they didn't get rid of it before they were arrested. A lot of the problems we're having around the county is dealing with methamphetamines. I need a solution somehow.
Well, yeah, and I agree. It would be great if there was other alternative treatments. We do treat individuals who are addicted to methamphetamines through our addiction treatment services program, but that's primarily through talk therapy rather than in the medicated assisted treatment for opioids is a combination of talk therapy and medication. There is no medication designed for methamphetamine addiction.
Okay.
That's the
Is
challenge.
there any kind of studies or any solutions? I don't know what the solution is. What we're doing is they're committing crimes, and so we're putting them in jail. And so now we've got people in jail, we've got the courts involved, we've got the DA involved. How can we break that cycle?
I just think that's a big question that we probably need to, we have a lot of community activity going on around trying to define what steps to take. It's a big issue.
It's an issue that we're not going to be able to solve ourselves, Commissioner. That's one of the reasons why we've got the new community collaborators working on this topic, because we've got to get a lot of different people involved. It may require different levels of treatment inside the jail. I don't know that to be sure. It may require additional levels of service being available in the community for folks.
I don't mean to interrupt you, but I keep hearing about these community collaborators, and I've asked to meet them on more than one occasion, and I still have not met them. So do they exist? Are they real? Because I would really like to meet these two people that we have hired that have been working for how long? How long have they been working?
About 6 months.
Okay, so I'd like to meet them
We'll bring them
soon.
by.
Okay.
And can we bring them to a board meeting of some sort rather than two and one? Because whatever they're doing needs to get out to the public somehow. Mm-hmm. And if we do two and one, why the public doesn't hear what they're doing?
We'll be glad to get them on the schedule.
And while we're on this topic, there's the 12-step program. There's all these programs out there. There's this one, the grid. I just wonder at what point, I know that you guys have been working. This is not me coming at you, not like you're working. But at what point do we, what's the saying? You keep doing the same thing and you expect something different. That's the definition of insanity. And so I just wonder, at what point are we going to think outside the box for different solutions for our community? That's really, I just can't stress that enough. I want to start thinking about different things. And if we haven't tried the grid, well, heck, why haven't we?
Well, all I can say is that I know that we have staff that are working on this problem every day, and they will continue to do so. And I think that they try different things from time to time. They're really interested in doing evidence-based practice services, and they'll continue to do so. And I think that they look at different alternatives, and I hope that we'll see some things from the collaborators as well that will identify some additional programming that we may be able to implement.
We do refer to community programs like the grid.
Yeah.
Lots of community partners.
All right, Deb.
So to the numbers, the property tax funds go towards 3 different programs: administration and operations, including Housing First, adult services, and crisis services. And then our non-tax funds support admin operations, including Shelter Plus Care. That's a big part of that number. Adult services, crisis services, children's services, medical services. Total budget, $42 million. And it's it's a flat budget. There is a little bit of additional revenue coming from the state, and so you see that Comcare revenue program going up a couple of $1 million. And here it is.
A lot of revenue generation. Wow. Wow.
And here's how that $47 million is split up. Bulk of it goes to personnel, and again, that contractual number, that's with community partners that we're working with and paying for services that they deliver as well. There are 3 different decision packages for Comcare. The first decision package is on page 477, and it's a community crisis mobile services. The request is to add 2 clinicians and 2 case managers to meet the growing demand for mobile crisis services. And these teams would go out into the community to deliver behavioral health needs to individuals that may not be able to get into the crisis program. And so I know that we talked before about community paramedics and that pilot program that we talked a little bit about a couple of weeks ago. This is similar, but it's focused specifically on behavioral health only. And so these would be folks that a family member may call in, an individual may call in and talk to the folks on the crisis line, and it becomes apparent that they should be talking to a therapist, but they're not able to come in. We would be able to dispatch folks to deliver services to them where they're at. And it's just a response to the continuing increasing need for behavioral health services in the crisis program and across the community.
So would this be something that if someone calls 911,
Yes.
they
Generally,
would kind of be trained to send this team out rather than
Right
police?
now, 911 partners with the crisis line very well, and so they'll transfer calls from 911 to crisis if it becomes apparent that really what they need to do is talk to someone at crisis. And so then crisis would dispatch. There may be times when it would be a direct dispatch by 911, but more likely they'd route them to the crisis program, and the crisis program would dispatch. And that kind of partnership exists right now. It's a good working relationship with 911 and our crisis line.
So if they're not dispatched on some kind of call, are they doing something else?
They're going to be delivering services to those walk-in folks. And right now, we struggle because we've got so much walk-in demand that we can't get to the crisis calls. And so we'd like to be able to dedicate teams to just do crisis calls, because we think that there's probably a volume of work that would keep them busy. But on those occasions when they weren't out in the community, there's folks in the crisis center that they would be able to work with.
Mr. Metzner has a question.
So, Tim, this other massive work we've been doing with, I'm going to call it the Dr. Gallagher group.
Mm-hmm.
So this is separate than the potential 3-person
Yes.
team that we dispatch?
Yeah. Those people would be responding to, I think the word is not, the language is non-acute 911 medical calls. It may be that what they need is behavioral health services. It may be some kind of social service type need that really prompted that phone call. These folks, and so that's the team that would go out for those, and 911 would dispatch those. This team is going to be folks where we know specifically it's a behavioral health issue, and we know that it's probably going to benefit greatly from both a case manager and a therapist on site with them. And there are folks in our community that may be experiencing a mental health crisis, and they just can't get into the community crisis center. Whatever's going on with them doesn't allow them to leave their home, for example. So we would be able to send folks to deliver services to them where the need is.
Yeah, but the 3-person potential, all these groups are going to volunteer a person, like the sheriff. We have a law enforcement, can't even remember, EMS.
Paramedic, fire paramedic.
And then I thought a social worker?
Yeah.
We that was just rolled out about a month ago when Gallagher came in.
Right.
We need to, between now and the time we roll budget out, Joan and Tim and I and the sheriff and Gallagher, we need to sit down and talk about the strategy. On this crisis mobile unit, I would say most of those calls generate from law enforcement out there, but it's not exclusive to that. I think private citizens can call and get access to that crisis unit to come. We have to see the Gallagher concept fleshed out a little bit more, and we're not there yet. But I do agree it's not making much sense to have all these mobile units out there if they're in conflict with one another. So we need to kind of talk through that.
Yeah. These mobile crisis services are probably going to be requested more often by a family member or by a professional in the community or a school. It's not uncommon for a school to interact with a child, maybe one that we don't have staff in, and they recognize the need for a behavioral health intervention that's beyond their staff's capability. It would be nice if we could dispatch a mobile crisis team to a school to help that child. Right now, we just don't have the capacity to do that. So the types of referrals I think that will happen that this team would respond to are primarily going to come either from family members or from professionals in the community. rather than a call to 911, which is what would trigger that other team to go out.
Was this group licensed to distribute medications?
No. But they would be able to connect folks to medications. It's not uncommon for individuals experiencing behavioral health crisis because they haven't kept up with their medications, and so they would be able to facilitate getting them in to see one of our med providers or whoever their med provider is.
Okay. Well, and I agree that the Dr. Gallagher group, we're not totally have our hands all around it yet, but we're getting close, at least for a trial.
Yeah.
So,
And I think that's
meeting. I think we have a meeting this week, actually. That next group, right? Joan, is that right? What's that?
I think it's on the 15th. There's a meeting this week.
15th, yeah. That's what I thought. Okay.
And I think that's another example of trying something new. That's a program that we haven't had in the community. It's one that we're going to pilot and see if that it works and see if it makes a difference. We have had success with mobile crisis teams in the past. We just don't have the resources to be able to deal with the folks that come in to get crisis teams dispatched out for mobile calls.
So how many people on average come in daily to the crisis center?
Oh, I don't know that we have an average. Sometimes we could be inundated with 100 people in a day. Other days it could be 75. But the issue is the complexity of the case.
Right. So that begs the question, how much time is spent with like each person if you had an average? I mean, does it take one staff member to one person for an hour,
Oh, minimum.
2 hours?
Yeah.
So I think
It depends on what the outcome of it is. If you have to find a resource for a youth for a higher level of care, it could take 8 hours to find a bed for that child.
and that one person is then tied up, our one staff member is tied up with that one person.
Or it could
And-
be as simple as a 30-minute, you screen them and give them support and admit them to one of our units or refer them to one of the community providers. So could be 30 minutes to 8 hours, but you're minimally spending an hour with each person.
And how many people work on average per day?
Oh, it depends on the shift because we staff it based on volume. Our first shift is pretty hefty. I think we have 8 or 9 clinicians on duty at any time, as well as the staff that man our observation recliners and our stabilization.
So if you had 9 people come in, you could have every single person.
We haven't been able to respond to a mobile request, but maybe one in 6 months.
And so mobile meaning you got to go out to their house. That takes travel time to get there. And then the minimum hour that you would be with them, right? And if you go to somebody's house, you're probably there even longer because you're in their home, right? So it could take up to 8 hours, you're saying. So that's one person leaving. So now you have 8 people if you're fully staffed.
Right.
Okay.
Yeah, we don't have the dedicated resources to do those. And it's heartbreaking when you have to say no and you know they're not getting help.
Do you?
We set up the mobile crisis half a dozen years ago, probably, and I was still in law enforcement at the time, and we were dependent on. I mean, it was nice to have that service to come out to the field, and then what ended up happening is that we brought crisis center open, and those people got consumed into that, and we lost that ability. So they're trying to bring it back. It is extremely effective for the community to have a group that can come out to you and not have to necessarily get them into the facility. Though inefficient that it is a real boon to the community to have that function. I can attest to that. We missed them, and you'd wait in line. I mean, they would not be available that much of the time, but when you could get them, it was a good thing for the patient, and it was a good thing for the officers that were at the scene. So.
And to Joan's point on Friday when we spoke, the time somebody needs help is when they ask for it. And so if we're not able to help those people when they ask, chances are they're going to ask again are slim to none. And then you find people dying because they didn't get the help. Or going to jail. Yeah. Not to be so dramatic, but.
Or just suffering.
Yeah.
Day in, day out. Yep.
But is it more efficient to have a mobile unit that goes out to pick and works with them in their home, or to have our EMS transport them back to you?
This may be more about effectiveness than efficiency. It's not the most efficient model for service delivery, but it's really designed around effectiveness, getting the service to the person where they're at. Lots of times folks will not leave their home. That's why we need to send services to them. They may not be willing to take an ambulance to the crisis center. And I'm not sure crisis can deliver to, I don't think EMS can deliver to crisis.
I don't either, and it's very costly if they can deliver them anywhere.
But Commissioner Meitzner's point, where we're forming this other team that's going to have someone on it that might be able to do that, I guess we're looking at two different ways to solve the same problem, it seems to me like.
Two different populations.
And again, we're trying multiple approaches to solve a very complex problem. We've got services that we deliver on site. In our crisis program, there are behavioral health providers all across this community who do 1-hour therapy for individuals, and that some of that works for them. The majority of psychotropic medication are prescribed by family physicians in this and every other community. This approach is a very broad and very complex approach, and I think we're trying to come up with multiple different solutions to try and have an impact.
But we're going to put $261,000 in the budget from here forward, where that we may have other ways of doing this.
We'll flesh this out, Chairman. I think before we put anything into a budget, we need to have better clarity, and that is going to call for Joan and Dr. Gallagher and that group, and we get together around a table and we discuss the most efficient, the most effective way to provide a mobile service, and we'll do it cleanly. We have not had a chance to flesh this out yet because Gallagher's concept is relatively new to us. But I think that if there is two populations out there, we need to define what those are and what each of these entities will do for us in the way of service, and we have not had a chance to do that yet.
Can we speak to it just real quickly, what those two populations are, Joan?
Yeah, I can. And Rusty probably speak to it better than I can because he oversees that area. But the intent of the Gallagher work and the group that's working on that is to better utilize EMS and other services. So it's trying to send a lower cost, more effective approach to people who are calling for an EMS response or a fire response. The population we're talking about for the mobile crisis unit are people who are calling and saying, my son is barricading himself in the basement. His health has gone downhill. He's got depression. Can you help us screen and determine what his needs are? Just two different populations because it's not coming into EMS or fire for a call.
But couldn't EMS or fire treat that? That's what I think we need to flush out, is how do we get the services to them? If we're developing another procedure for EMS, is that going to work for you or not?
These ones aren't probably going to call 911. They're calling us. They're calling our crisis
But
line.
why can't you call 911 and send this team out?
I would have to say that EMS is dealing with a medical condition, wouldn't that be correct? I mean, these people are.
Well, it could be. To me, the Gallagher group, that trio of people, we get calls all the time if somebody's just down. There's a person that's passed out or down along the river. This team could go, because you don't know what you're going to get there. It could be drugs and alcohol, could be mental, could be physical, could be heart, cardiac. I mean, so that team bears all of these resources and will be able to solve it no matter what it is. That's how I view, and the Gallagher concept here, that group is pretty new, but that's how I see that group reacting, is going to these unknown calls and aiding law enforcement, sheriff, and WPD to solve these cases, in lieu of taking somebody to jail or just not knowing what to do with them. The mobile crisis group is specifically for, you know what you're getting. You have a mental health crisis happening. It's been articulated that way. There's no unknown here. This mental health crisis team is going to go out and try to help and give suggestions and treatment to those people. So I see a little bit of a difference, but we do need to dialogue more about how they're going to interact and how this is going to operate.
I might clarify just briefly. The community response team model that Dr. Gallagher and fire personnel have been talking about. That group would be largely responsive to the 911 call volumes, like the manager said. Calls are going to come into 911. Some of them are going to be readily identifiable as a crisis situation that a regular patrol officer or deputy can manage as a, if they're trained. But this group could go out and deal with multiple issues. This is, it could be mental illness, it could be substance use, it could be a social type problem, and they can go out and evaluate the law enforcement officers there, so they can use their legal authority, if need be, to move this person from one spot to another. EMS can make a medical clearance so that they don't have to go through an ER if they need to go to crisis or somewhere like that. And more than likely, the social worker on scene may be able to resolve issues with them. There's enough volume of work out there, and there are different populations. There are times that crisis will have a family on the phone who's concerned about a loved one. They don't have anybody to send out. They'll attempt to send law enforcement out, and when law enforcement arrives at that site, based on their limitations through state law, they ultimately will be able to provide no services whatsoever, because unless they see some indication that this person is a threat to themselves or other, some type of behavior that causes them to have a lawful reason to take this person into custody and force them to do something that they don't want to, ultimately they are unable to provide assistance, and so they refer them right back to crisis. And what you have is people who won't come out of their house, who won't go to crisis. This mobile unit from crisis will go to them rather than trying to send law enforcement to something that law enforcement can't resolve. So there are some overlaps potentially, and that's where we need to sit down and better hash out the best, hopefully a best solution. There is some overlap, but there are some distinct differences in the population. So it's like Tim said, it's very complex, and there's not one size fits all type solutions to what goes on out in the community. So we will work on that, and as Commissioner Meitzner indicated, there's a meeting this week on the 15th to vet this out a little bit further as far as the CRT model is concerned. So.
And Joan, you're part of that group, right?
Well, I have been, but I noticed I don't have an invite for that meeting, so.
She will. I don't have one either, but we'll get to it.
Okay. And you're going to send these out as pairs or one?
Pairs.
Yeah,
As pairs.
I actually won't be able to attend that, and I'm really sad. Is there a way that it could be recorded in some way, shape, or form?
They are.
They are recorded? Okay.
If not, we'll get you a briefing. Yeah.
I believe, WSU is helping facilitate it. I got the right meeting.
Okay.
You can't have a half hour on every decision package, Tim.
Okay.
All right, Tim.
Yeah, that's sorry about that discussion. I think it was important.
No, it's important. I agree.
It's a good discussion. And the next decision package is attached also to the Community Crisis Center, and it is a request to add one program manager and one team supervisor to provide additional supervisory support in the Community Crisis Center. Community Crisis Center is a 24-hour operation, 7 days a week. We staff that through the heaviest periods of time with full-time staff, but we also supplement that with a number of part-time staff. And some of those part-time staff may work one shift a week. They may work one shift a month. It may be a Sunday afternoon or a Saturday overnight shift. But those folks have limited contact with our supervisors. Even though we've got supervisors that work into the evenings, we know that we would be able to better support those staff that are dealing with increasingly complex visitors and guests to the crisis program if we had some additional supervisory support there. And so this request is to add 2 additional managers to that program so that we would primarily be able to deliver support to those individuals that are working nights and weekends, and have some additional clinical expertise in the building, because as I mentioned, all those folks, the folks that we see now are maybe more complex. There's more substance use involved, and so that's the request there.
Questions on this package?
The third decision package is a request to add some some part-time contract security at our children's program. Children's program is at
Waterman and Broadway.
Thank you, which is not very far from the work release center. And evening hours have become a little bit more challenging for our staff, and so we'd like to be able to add security because folks tend to wander into our building because it's one of the few that's open at night. And so we'd like to be able to have some contract staff or security staff in the building at that point in time, just from 4 to 7. We like to be able to be open in the evenings because that's a good time for families to be able to bring their children in, but we'd like to add some security for our staff as well. So the 3 decision packages total $437,511, includes 6 FTE. And there is one alternative reduction in the Comcare budget, that is to reduce, I think we discussed it already in Wes's budget, reduce the grant-funded IT position that was supporting the electronic medical record. Comcare is in the process of upgrading their electronic medical record, and so they don't need a DBA, database administrator, to help manage that. And so it's appropriate to shift the cost of that away from the Comcare program because Comcare won't be utilizing that staff person any longer. And that's an $82,000, $595 package. Any more questions about Comcare?
Any questions on Comcare? Very good.
One statement, just to kind of get back to what Commissioner Cruz talked about. Comcare, the bulk of this budget is state. And so the challenge for Joan and her staff is to manage these dollars, and it's, as Tim mentioned, is highly complex. We've talked about this a lot in the last month and a half. And so often when you accept those dollars, there are best practice outcomes that this is a science. We're not guessing out here. There's best practice outcomes that they put us into, and they demand that we follow. That's why when you say thinking outside the box, it's very challenging to get outside the box, because there's this best practice outcome framework set up for us that we have to fall into. Not saying that it's impossible to get outside the box, but those are some of the challenges that we face as we talk about new ways to manage this and new ways to get and get the analytics better, and to talk about where the gaps are at, and to get at this strategically. It's just very difficult, but we will be working on that between now and the time and the budget and beyond. I mean, this is so complex of a topic. So I appreciate the comments on that, and I know Joan and her staff work very hard and will continue to work very hard, but just keeping in mind that a bulk of these dollars are state dollars flowing to us to provide these services. So I don't know what the percentage is, but it's the vast majority is
80-20. Yeah, it's 80-20.
80-20.
Yeah.
So this request decision package is 8%?
No, that's going to be 100% us.
Okay, thank you. I like 80-20 better.
The CDDO's mission is to assist people with intellectual and developmental disabilities to receive quality services and achieve greater independence. The division achieves this through 6 different programs, 1 property tax funded initiative, and then the rest of the services are, again, that state funding. Those programs include operations, service access and outreach, quality assurance, state aid, administration and finance, and then capacity development. The Cdo Strategic Results include that by 2019, 80% of the individuals with IDD living in the community experience life according to their preferences as described on their individual plan, and in 2018, 74% of those individuals were receiving services described by their personal support plan. And their other strategic result was that 20% of the individuals living with IDD currently in an institutional setting would be transferred to a less restrictive community-based alternative, And that is a much more daunting goal. And 5 people have transferred out of Parsons State Hospital in 2017. And again, it's a tough challenge to overcome to get folks to transition from the hospital to community-based living. The one property tax funded program in the CDDO budget is in the operations unit, and it is designed to allow the CDDO to continue to operate as a service coordinator rather than a service provider. The state statute requires that CDDOs assure that there are crisis settings available for individuals experiencing IDD. In some communities, the community service provider, the CDDO is also a community service provider. In our community, a number of years ago, it made the most sense for the CDDO to be a service coordinator and not deliver direct services. So Starkey, Catch, Rainbows, and another roughly 45 different organizations in the community, some for-profit, most of them nonprofits, delivered the direct services to individuals experiencing an IDD. The CDDO manages that program. This funding allows the CDDO to make sure that those folks that are in crisis have a place to go so that we don't have to deliver that direct service. I think this service model works a little bit better because we do have so many providers in the community that are really skilled at delivering services. Service Access and Outreach is a state-funded program. It is the program that is the referring organization that helps determine eligibility for individuals and then make information available to them so that they can choose the type of service provider that they would like. In 2018, there were 2,535 individuals eligible for IDD services in the community. And one of the things that the Service and Access Outreach folks do is help determine that eligibility and then make referrals. The Quality Assurance Program makes sure that the services that are delivered by those community partners are safe and effective and appropriate. And those 46 different providers operate under state statute and also the contract requirements that we impose upon them. And so we've got staff who do site visits, they do desk reviews, they do chart audits to make sure that the services that are being provided and paid for by the state are appropriate. State aid funds are non-tax funds that come into the community and they're distributed by the CDDO to local stakeholders, providers, to meet needs that aren't necessarily met by the waiver. And so there's a funding process where individuals, case manager, can work with their case manager to apply for additional funding. And there's a process that those requests go through, and then the state aid is allocated through that process. Administration and finance is the support for the organization. Again, CDDO manages care for 2,500 individuals with 46 different service providers in the community, and they make sure that the provider system is adequate and providing appropriate services. And then finally, we've got a capacity development process that Dee runs. She generally does an RFP process and tries to identify alternatives to services or do some outside of the box thinking with that. And in 2018, she funded 4 different programs. The 2 largest were for technology-related service implementations. So the Disability Cocoon organization is going to help redefine supports through enabling technologies. And Good Life also does technology. They use a product called iLink, Experience and Dissemination Center. And so those are 2 different heavily technology-dependent service models that we're bringing into the community to see if they can make a difference in more individuals' lives and try and expand the capacity of the CDDO and either deliver better service for the folks that are being served or hopefully bring some folks off of the waiting list as well. And again, there's an RFP process, and outcomes are negotiated and identified through that process. So the property tax fund request is level $1,956,590, and the non-tax fund request is $3.6 million. Again, those are state funds. Total request is $5.5 million, flat request. And there you can see how that money is spent. And there is a decision package. No, there's not. The decision package was part of the TRB request. So, pardon my mistake there. D does have a request for a new electronic medical record, but you'll see that as part of the TRB request. Any questions about the CDDO?
Let's see.
Okay. We'll move on to aging on page 493. Aging's mission is to assist older adults, caregivers, and persons with disabilities to achieve improved health and greater independence. They've got 5 different programs: administration, community-based services, in-home services, physical disability services, and then transportation. And like the other programs that we'll talk about today, this is a mix of both local funds and a lot of state and federal funds as well. Their strategic results that they've been working on were that 95% of older adults in Sedgwick County are able to stay in their homes, and in 2018 their result was that 95% were staying in their homes. By 2022, Medicare beneficiaries would receive $300 in cost savings as a result of SHIC counseling, and up to date so far they've saved $263,912 in cost savings for individuals. And then by 2022, that 50,000 individuals be provided information, referral, and assistance for services that will help them remain in the community. And through 2018, 37,076 individuals have been provided INR assistance. And again, Aging's mission is to deliver services to help individuals stay in their home and in the community, and services are provided both to the older adults, their caregivers, and individuals with disabilities. And those services are provided by a mix of Aging staff and staff that work for other organizations in the community. Annette partners with a number of different organizations for service delivery as well. Aging administration is responsible for the things that you would expect for an organization, so operations, finance, facilities, and making sure that there's an adherence to policies and procedures. And in 2018, the department initiated the development of a five-year strategic plan. Their community-based services are funded by both property tax and state funding and federal funding. Community-based services are designed to, again, help individuals maintain their health, community living, and avoid more costly levels of care. They delivered services to 14,041 individuals through programs that were funded locally, including adult daycare, prescription drug assistance, RSVP, legal services, and senior centers, and they served almost 90,000 individuals through grant-funded programs, many similar, also congregate meal programs, caregivers. They do nursing home assessments for individuals, and a lot of information and referral and options counseling. And again, those services are provided by staff and by staff of other organizations that contract with the Department on Aging. In-home services are, again, similar to those community-based services, but they're designed to help older individuals maintain their home status, keep them from going into a higher level of care and out-of-home placement. The number of different services provided: 364 individuals were helped with local funding, and over 6,000 individuals served through grant funding. The PD program is funded by local property tax funds, and that service is available to individuals with a disability regardless of their age. So in this program, there may be individuals younger than 55 or 65, as whatever eligibility may be for other aging programs. This service is available to anyone of any age, provided they meet that disability criteria. 516 individuals were helped. Those services are provided by contracting organizations. And then transportation is, again, a mix of funding, local funding and state funding. And the goal is to help individuals meet that whatever transportation need they may have based on the funding available. And again, it's designed to help get them to appointments or do things that they need to that allow them to maintain status in their home and in their community. We offered 4,377 rides with local funding and 18,000 rides with state and federal funding. And the aging department has a transportation brokerage, and they do a lot of work across the community to help get people where they need to be. The property tax fund request is $3.1 million, and you can see how that's split out there. The non-tax fund request is $7.6 million, so again, that's about a 75-25 split. And the overall request is $10.7 million, so it's a flat request. There is a decision pack. There are decision packages for aging. Their first decision package is related to the nutrition program. Annette would like to introduce a meal program for homebound individuals who live outside of the city limits of Wichita. Right now, the current Meals on Wheels programs only deliver services within the city limits of Wichita. Annette's identified a program that would help deliver meals to individuals that live outside of the city limits that may not be able to get to congregate meal options in whatever their home community may be. And that request is for $59,995.
I see in the decision package that it's a grant award.
No, this would be no levy.
This is a request for local funding.
So on page 515, just help me understand what this grant award is then. Am I not talking about the same thing?
That's the POE, which is how they'll pay it out, but will be in the tax fund.
Okay.
It's a grant award to another organization. We wouldn't deliver the meals. We would
gotcha.
award the funding to another organization, and they would.
Tim, I don't want to get too much in the weeds. How many people outside the city limits are we talking about for a nutrition delivery? Is there
Come on up.
Is there a heat map that says it's a bunch here and nobody there? And I'm just wondering if
part of this program would include an assessment. So someone would call. They're probably going to call the ADRC and talk about meals as a challenge for them. And so part of this program would be sending a staff person out to do an assessment, determine their eligibility. And I'm going to let Ann answer.
So we don't have exact numbers. We do know that, according to the last data I looked at, about 76% of all the population that lives in Sedgwick County lives within the city limits. So the rest of that population lives outside the city limits. Because we don't currently have a program that serves this population, we don't have a waiting list. So, but we do know that there are older adults that live in the rural communities within Sedgwick County. We know that they're out there. We have a congregate program through our grant funds that serves those. But for individuals who are not in those specific communities or who are homebound, they can't get these services. So we don't have exact data, but we know that the need's out there. This is a fairly expensive program. As you can imagine, it's 5 meals a week. It's 1 meal a day for 5 days a week. So we do feel that from calls that we get in and from when we're out in other communities, we know that there are people that need this program that don't have that capacity at this point.
Okay. So if a resident lives in Derby, would this program deliver meals to a Derby resident?
Well, Derby does have a congregate meal program, so
Okay.
if they're able to go
Probably
to that,
not
but
there.
if they are homebound, then we would be able to meet the needs of those individuals outside the city limits of Wichita.
Who provides the service for us? Who do we award this grant to?
Well, at this point, we don't have a service provider. We do know that there is one out there that we use in some of our more rural parts of the 3-county area, mostly in Butler and Harvey, because under our federal grant program, we serve 3 counties. So we have a meal provider called Mom's Meals that does delivery of meals, and they deliver it once every 2 weeks. So it is a FedEx service that we've used in those areas with some federal dollars. So that would be one option we could look at.
Commissioner O'Donnell?
That's what I was going to ask Annette. So I know, like with the Hayesville Senior Center, and we help them with funding, but they told me that the people that provide meal delivery for them also, I think it's in Sumner County, maybe, they deliver it to Wellington as well. And
So your congregate meal programs are funded with state and federal dollars, and we have a provider through Central Plains Area Agency on Aging called API. They also serve the South Central Kansas Area Agency on Aging. It's pretty much a donut around Sedgwick, around us. They go up all the way into Reno and then down into Sumner and Cowley County. And so we contract with that provider. They do deliver congregate meals to the congregate programs for those who can get out, and they do some limited home delivery. They do short-term delivery for people that have been in the congregate program, but there still is a population of individuals that reside in areas in Sedgwick County that don't have a meal service available.
right. Thanks.
Okay.
The second decision package is for senior centers. Prior to the budget cycle, we did an RFP and allowed senior centers to make requests for additional programming or services, and the Aging Advisory Board recommended to support 4 of those requests, and the total of those requests is $1,726.
Looks like it's more than that.
17,000.
Comma's in the wrong spot.
Yeah.
Is it 17,000 or?
It's 17,000. I apologize. And the final decision package is for a position, and what the request here is to do is to add an FTE and allow Annette to manage some of the funds that are in her current budget to provide case management services that aren't being offered right now. And so Annette recognizes the need. She's got some resources available. She would like to be able to fill a staff position and deliver those services in the community.
What portion of this budget is used to advertise your services? How are you getting the word out? You know, if we have money in our in-home services that isn't being utilized now and it's being transferred to something else, how are we reaching those people that need to be reached?
One of the tools that Annette has available is she operates the Aging and Disability Resources call center, and so that's advertised statewide, and those calls come in from across the state, and she and her staff are delivering information to people across the state on how to get services. But most of course, because of the population density here, most of those calls that are coming into the ADRC are from Sedgwick County residents.
So like Tim said, we do have the Aging and Disability Resource Center, and that is advertised and marketed some by the state and some by, because that is a state-funded program. We do also put out information in the Active Age newspaper that reaches about 50,000 households throughout the 3-county region. We pretty much always have a story in there, so we put advertisement in there. We really don't have any specific budget for advertising. We do a lot of work with partners. We do a monthly aging network meeting where we get about 70 different providers that come in. So we get information out to them on a monthly basis and provide information on our services. Because we do the nursing home assessments, we work with all the nursing homes and hospitals so that they know about our services. We're out in those services, out in those facilities on a daily basis. We also do all the Medicaid waiver assessments for the frail elderly, the physically disabled, and the traumatic brain injury. So all the professionals that work in those arenas know about our services. We also do a quarterly senior summit meeting where we bring in all the senior centers and provide them information and updates. We do the annual Senior Expo event where we get over 3,000 older adults and caregivers that come in. We have staff that do health fairs and go out and do different events across the community on a regular basis. We also have a staff member that goes out and does community education to different events, to different providers and different networks. We go out to places where seniors are and provide those kinds of opportunities and educational sessions.
But for those people who aren't getting out, who aren't connected, who are homebound, who read the paper, who do that kind of thing, you know, working in senior living, it's a really proud generation we're working with here, and reaching those people who haven't been reached, you know, growing those numbers, the people who don't go to the expo to get their bag full of squeezy things. I mean, it's those kinds of people that I feel like that's who we should be reaching out to. If we're trying to keep people in their homes, you know, they become isolated, those kinds of things. So, you know, again, reaching outside and thinking outside the box. You know, we've been doing these things and you're doing a great job, but what are we doing on top of that, and not just doing business as usual like we have been for X amount of years?
So a couple of things there. We've got the strategic plan that Tim mentioned that we're doing, and one of the areas that's going to be one of our 5 areas of focus is education and outreach, and figuring out how to do that in a different way, really thinking outside of the box. So doing that and trying to figure out new ways to do it. Probably the active age is pretty much the only really advertising that we've done, except from the ADRC. That contract is being renewed probably within the next month, and there will be, we believe, some funding available for advertising and marketing in that would give us a new opportunity, again, to think of new ways to do that.
So as I travel around my district and I go to a bunch of different churches, I mean, what are we doing in religious institutions that may, you know, they each on the back of their bulletins, they have their shut-ins. You know, have we reached out to those kinds of folks? And at what point do we make it a point to let the churches know? Because everything starts in this community really around that.
So we have a caregiver coordinator who works a lot with our local churches and with the Interfaith Alliance and different groups. So she does a lot of work with those entities as well to share the information, because like you say, we recognize that a lot of the older adults in our community are engaged with churches, and that's an excellent way to get the information out. But I'm sure there's more work we can do in that arena.
Okay. Commissioner Howell?
Thank you, Mr. Chairman. Hey, thank you for the presentation. I have a couple questions. Probably might as well just stay up here. I see your calculation of $59,995 for nutrition. Can you tell me how is that calculated? Or I actually have some different numbers here. That's why I'm kind of wondering where that number came from.
Well, because we don't really have exact numbers, and we don't have a waiting list, so we were just kind of coming up with the number to start the program and figure out kind of based on some other programs we're doing with the Area Agency on Aging, and we have a smaller budget than that, but we know that the population exists. So we were figuring that would serve about 9,100 meals.
Just a second.
Okay.
I'm sorry, I missed half your answer. I was trying to.
Because we don't have a waiting list, and we don't really have exact numbers. We were kind of looking what we're doing with our Central Plains Area Agency on Aging. We have a small budget where we're providing a similar program to this, mostly in the other two more rural counties. So we looked at that and we came up with this number, and that would serve about 9,100 meals.
According to a letter I received from someone, Laurel Alkire, I guess she's part of that program, I understand. They're saying there actually is a waiting list, and apparently the Aging Advisory Board suggested 31,798 just for the waiting list itself. And
okay, and that is for their senior services does receive both local meal levy dollars and state and federal funds to serve home delivered meals. However, they only are, because of the way they really, most of their deliveries are done by volunteers, so their service area is the city limits. So they do have a waiting list that is for individuals residing in the city limits. And this would be targeted to those people that don't currently have a resource for home delivered meals.
Well, I understand that the Aging Advisory Board did vote to, they wanted to fund that 31,798. On top of that, I believe there's a posture seating program they wanted to fund for 46,800. This is a result of conversations with Pat Jonas and David Kemp. There is apparently they're short a repair person to repair these wheelchairs, and as they're not being repaired, the people are homebound. Can you speak to that a little bit?
Sure. We did receive some requests after the deadline of submitting decision packages through the budget cycle. We've got a deadline that we need to submit requests. So the Aging Advisory Board did reach out to a number of providers and ask them if they had any needs as well. And I think you've received information about some of those requests, and we're working with with the advisory board to develop a letter so that they can submit that additional request outside of the budget cycle, because it did come in after the budget cycle.
We typically only meet once a month, and I think they met last Wednesday. So my guess is I probably won't see this for about a month from now, because it'll take that long for that letter to be presented and approved by that board. So I guess very late. I guess I'd like to know sooner than later what the requests actually are. I don't know if we can ask for that information that they did vote for. It'd be nice to get that information to this board. But as I've got it right here, it shows that they wanted 46,800 for the posture seating repair for wheelchairs, so people aren't homebound because the wheelchairs are broken. There's also a disabled Meals on Wheels program for people who are on a waiting list. That's 34,202, and then another 31,798 for another waiting list for Meals on Wheels. I don't know what all that adds up to, but and then I'll let you comment on that. And I have one more. Go ahead.
We'll compile those additional requests that have come in, and we'll get that to you. It's difficult to figure out what's the right format to do that, since it did come in after the deadline to submit decision packages. But we've been working with them to try and formulate a letter that would help them. And it sounds like they did formulate a letter if they sent it to you. But we'll work with them to combine all of those requests and share that with all the commissioners.
Okay. Have we calculated a mill levy equivalent for 2020's budget?
I'd have to look to Lorian for that.
At this time on your long sheet, it shows .460 mils as the estimated 2020 mill levy rate.
That's an increase of 0.04.
So that
Was 0.42 last year. Actually, 0.04. Pardon me?
0.032, it was .428
Okay.
in 19.
428. Okay. And I see on here you have a package of 17,628 for 4 senior centers. Can you tell me how that breaks down to the 4 centers?
And that has that information. You got the requests, what they're for.
Okay, it was $2,500 for Hayesville Senior Center for a chair yoga program. It was $6,770 for Mulvane Senior Center for evening dances and a computer education class. For Park City, it was for community engagement program and a training program.
How much was that one?
$3,036. And for Valley Center Senior Club, it was $5,321.86 for a computer lab.
Okay, and that's the 17,000.
Yes.
If I understand the process this year, there was a letter that was sent out to these senior centers asking them for the budget request. Some of this, I think, is one-time money. This is not going to be recurring money.
I think it's recurring money. I mean, we typically that's the way the budget works. So, okay. Because it was, we sent out a letter to all the senior centers and notified them that if they had additional funding requests for specific program or needs, if they would submit a proposal, and then the advisory council reviewed that and made decisions on these.
Yeah, and I attended that meeting. I understand that, like that $2,500 for Hayesville, that's for chairs. You said that would not be recurring, would it?
Said yoga.
There was another proposal that came in.
It's a chair yoga.
It's a chair yoga program. I'm sorry.
Chair yoga.
Yes,
program.
Chair yoga at Hayesville Senior Center.
Well,
so
anyway,
it's a specific program.
All right. I guess in addition to the things I already brought up a minute ago, there was another, again, one of the votes was for supplemental funding for the Oakland Senior Center. And just to my colleagues understand what I think I know is going on right now, and that is they have been receiving $35,000 that, according to the old formula, which we're not using now, but they would have been eligible for $22,000 additional, and about the last several years they were eligible. We didn't fund that, but nevertheless they're funding for the Oakland Improvement District. Right now, 1 mil generates about $7,000 in property tax revenue, and they do subsidize that senior center heavily. Many of the members, I would say probably 80% of the members that associate with that senior center are not Oakland taxpayers. I should say not Oakland Improvement District taxpayers. And as a consequence, we discovered a statute that's going to take their mill levy from around 15 down to about 5. So they have just a little over $100,000 in property tax revenue per year currently, but next year it's going to drop by about 2/3. So they'll only have 1/3 of the revenue left. So they're not going to be able to subsidize that senior center next year. As a consequence, if we don't provide additional funds this year to that particular senior center, it will not survive. And they service somewhere just under 500 members associate with that senior center. So I just like to say that I know this was a late request according to the timeline we gave the Aging Advisory Board, but I'd like to be clear to everyone that unless we provide additional funds to Oakland Senior Center, and I would say around $30,000, that's about what they've been getting from the Improvement District to operate. Without that type of support, that senior center will not survive. And by the way, it's a community resource. They use that senior center for all kinds of things for that community. It's very, very popular and very heavily depended upon by that community. So, to me, this is it's a request I think we ought to at least consider at this point. I don't know if we need to have a more robust discussion at some point. I think there's other things we should talk about with respect with how we manage the money for senior centers. I think there are some legitimate concerns. For example, the membership. I think the membership ought to be a county-provided membership portal rather than each of the 17 senior centers doing their own thing. I think we ought to do that as a county. The reason I say that is because some of these members associate as a full-time member to many of these senior centers. And the way we count those numbers in the old formula, it was kind of made an argument that they should receive more funding than perhaps we would want to provide. But that's just one example. I think that the membership ought to be a county portal where they would receive membership credentials if we wanted to continue to do any type of funding formula based on membership. On top of that, I'm cognizant of the 1982 ballot question that passed. The ballot question passed 2-1. That is still in place today. It doesn't mandate a certain level of funding, but it does limit funding to 1 mil. But I think the original intent of that ballot question was clearly that Sedgwick County would levy a new tax to provide service programs for the elderly. In fact, that's exactly what it says. And that passed 2-1. And we've continued to see the mill levy funding for these programs have continued to decline over time. And last year, not so much this year, sounds like it's going up a little tiny bit, but last year was a new record in terms of the smallest amount of mill levy funding we provided since 1982. And with that in mind, the senior population in Sedgwick County has nearly doubled in the same time frame. So I think we have got some converging lines, and it's going to get more challenging as time goes on. The goal, of course, of these programs is to keep our seniors in their homes and independent and thriving and healthy and happy as long as possible, keep them off Medicaid. I think that's a very noble goal. Providing exercise and education and nutrition and socialization, transportation, doctor's visits, safety, and other things that are similar to that. We can encumber those funds specifically for those types of services. It doesn't have to be for tablecloths or pickleball. Okay, it can be for things that we value as a county taxpayer grantor of funds. We can encumber those funds specifically for certain types of services. And I guess what I'm saying is we have to grow this up a little bit and have that more robust discussion about how these funds ought to be used to make sure people stay in their homes as long as possible. I see she wants to say something.
I just want to make just a clarification on that aging tax levy rate. We do have a reduction, but that's also because we're trying to draw the fund down to that target fund balance on that long sheet in row 53. We say we're trying to get that fund balance down to $200,000, and so we have been reducing deliberately that mill levy rate, not because we're trying to reduce services. In fact, I think last year the services were increased by about $100,000 for this budget. But I just wanted to clarify, particularly for the new commissioners, that we're not trying to reduce services by doing that. We're trying to get to a fiscally prudent fund balance by taking that action.
And that fund balance goal is internally set, though.
Yes, it is.
So that's what we choose to do through policy debate here. Once again, if I see that there's needs out there in the community for aging services and we haven't hit 1 mil, I think we ought to have a discussion about whether we want to do that. Now, one of the things I've talked about personally, and I don't know if anybody, my colleagues would agree with me or not, but the Aging Advisory Board, in my opinion, should be empowered to provide, if you will, a deeper recommendation of what we can do to provide the best services for our seniors across this county. Aging Advisory Board, their messages don't get to us for whatever reason, and they're not really empowered to communicate with commissioners. Some of the messages get filtered. And having said that, we politically debate what we want to fund, and sometimes things are approved, some things are not approved. It's very political. To the extent we haven't hit a maximum amount of dollars and there's needs out there, I would like to know what the needs are, so we are aware of what we're not funding. And so one of the things I would like to do is see us pass a resolution that would simply declare a mill levy funded department. 0.50 mills, for example, would fully fund everything in the Aging Advisory Board's umbrella, and then some. So we could consider that. And the reason this is different than everything else we do is because of the ballot question. I don't think we should do this with everything. The zoo was funded this way at one point. We do currently fund WSU this way, but because of the ballot question, I think this ought to be considered a choice we would make to simply calculate their dollars and then look to the Aging Advisory Board for how to best spend those dollars to help them the greatest number of seniors in our community. And it takes the politics out of it. And as the economy grows, their dollars will grow slowly with the economy. I think it's a worthy discussion. I think that's a better way to go, and I'd love to see us consider that seriously. But right now, without additional funding to Oakland, they're going to close. And I've asked them directly if that's true, and they said absolutely. There's no way they can sustain that. The wheelchair repair person for 46.8, in my opinion, is money we have to put in their budget, as well as the waiting list for Meals on Wheels 31,798, as well as the disabled Meals on Wheels program would be an additional 34,202. Whatever all that adds up to, I'd round it up a little bit. I think we need to make those adjustments in the budget request. Thank you, Mr. Chairman.
Any other questions from the commissioners? Thanks, Annette.
I'm going to move on to health, page 519. Their mission is to improve the health of Sedgwick County residents by preventing disease, promoting wellness, and protecting the public from health threats. Programs included today will be administration, preventative health, children and family health, and health protection. There are a number of statutes that outline the work that the health department does, and those are listed on that first slide there. The administration program provides, again, the traditional finance, budget, facility support to maintain compliance with Sedgwick County policy and the limitations that are imposed by federal and state grants as well. Also funded out of administration is Project Access. That's a partnership program that I hope all of you are familiar with. It's administered by Central Plains Regional Healthcare Foundation, and they leverage donated medical care, prescription medications, and durable medical equipment for the uninsured and low-income residents in Sedgwick County. City of Wichita and United Way are also funding partners, and in 2018, 1,149 patients were served, including 2,600 donated diagnostic medical tests. And the health department also, their central supply organization, which is part of administration, manages almost 23,000 immunizations and medical supplies over the course of a given year. The preventative health budget includes a number of different functions and activities, including family planning. They served over 5,200 individuals last year, or 5,200 office visits for 2,900 clients. And the goal, again, is to help men and women of childbearing age prevent low birth weight, premature births, and infant death through healthy birth spacing. The maternal and child health care coordination function provides family planning and STI clients under the age of 22 with some additional counseling to help reduce low birth weight, premature births, and infant deaths. And they served 1,392 individuals last year. 99% showed improved understanding of their health literacy. The Sti Clinic is a clinic that manages and tries to prevent the spread of infectious disease through testing, diagnosis, and treatment. They delivered over 7,000 tests to almost 2,000 residents, and 97% of those clients with a positive STI were treated within 14 days. And the goal is 95%, so they exceeded their goal there. The health department provides an active and robust immunization program. They provide immunizations to adults, children, and they provide travel vaccinations as well. They also do TB testing and blood pressure checks for folks. They provided almost 21,000 immunizations to over 7,500 clients. Lab services, the health department manages a lab because they are able to do on-site lab screenings and results for those STI clients that come in. They provided, in addition to a number of other labs, they provided 21,556 tests last year. The Children and Family Health Program is both locally and non-tax funded. The WIC program is designed to make sure that there are appropriate nutritional guides available for children and mothers. The goal is a reduction of low birth weight babies and nutritional support for low-income families, children, including children up to the age of 5. There were 19,890 women, infant, and children that were enrolled, and those folks accounted for almost 46,000 clinical encounters. And 74% of the new moms in the WIC program initiated breastfeeding, which is an important health outcome for children. The Healthy Babies program is designed to connect with new mothers and increase healthy pregnancy outcomes and early advancement for children through that 18th month of age. The FEMA program reviews infant mortality and makes recommendations to help reduce risk factors related to infant mortality. And there were 1,200 moms, dads, and infants that received services through the Healthy Babies program in 2018. The Children's Dental Clinic screened almost 19,000 youth in 54 different schools and served 320 children, and 10 pregnant women also received dental services. And this is a program that is staffed by some county staff hygienists, and it manages 23 different volunteer dentists and oral surgeons who donated almost 1,400 hours of their time and services to the dental clinic, which represents almost $420,000 worth of dental services. The Health Protection Program is designed to help reduce the spread of disease, and their goal is that 95% of reported diseases and conditions were investigated within the KDHE guidelines. And they do that through their STI control program. We've got staff that interact with individuals who have been identified as having an STI, and they contact that individual and partners to try and make sure that they stem the spread of that disease. The TB control program is designed specifically to address folks with active TB and TB infections and those individuals who may be at risk. And they do that through an investigation program and an education program. And in 2018, they delivered 1,986 services to 355 clients, 9 of which had active TB. And they do that both in person and through televideo to help limit the amount of cost associated with transportation for that program. And then our epidemiologists are busy tracking all sorts of different diseases and conducting investigations throughout the community. In 2018, they conducted 1,223 different disease investigations. They're in constant contact with local healthcare providers, hospitals, emergency rooms, and they're really the first warning for our community in case there's something bad happening health-wise. Animal control is responsible for making sure that both citizens and their animals are safe and healthy. They responded to 3,547 field calls and 113 animal-related emergency calls, and they're a very busy, active group out in the community. Public health performance monitors and assesses the health of the community. They work with the Community Health Improvement Plan and the Community Health Assessment, and they're involved with a number of different partners across the community to make sure that we are all healthy in that regard. And they had, in 2018, they also worked with Safe Streets. Safe Streets received a grant related to opioids, and they worked with Safe Streets to implement some of the outcomes for that particular grant. The property tax request for the health department is $5,231,924, and that is a flat budget request. And the non-tax fund, again, state and federal funds, $7,089,814, a flat request. And you can see the programs that goes to. The bulk of that, again, goes to children and family. Overall request is $12,321,738, and there are two different decision packages for the health department. One is for a drug misuse epidemiologist. Health department received a limited short-term grant, some limited short-term grant funding that allowed them to start to investigate much more robustly the use of illegal drugs and assembling both health department data, sheriff department data, and hospital data to look at the incident where drugs are being used in the community and the impact that they have. That funding goes away at the end of August, and we don't really have another resource in our community to do the type of data analysis that they're doing at the health department. And so this is a request to fund that position.
We have a question.
So I'm going to ask the same question you asked earlier. You know, what are we doing as a health department? This is opioid. We have a problem with meth. What are we doing as a health department to work to combat that problem?
I'm going to let Adrian come up and talk about some of the different activities that they're involved in the community.
I was just doing some, little Googling about meth, and really the only way I'm seeing here, there's not, outside of a 12-step guide, what does this person do for opioids that they couldn't do for meth?
They are doing the same thing.
Okay.
And so the grant that we have currently is focused, came down from Congress, passed through the state, and is focused on opioids, but I went ahead and expanded that. So the two part-time staff that we have are gathering data on all drug misuse in the community. And also through that grant, we're working with one of our community clinics to help them better implement SBIRT, which is Screening, Brief Intervention, Referral, and Treatment. It's different assessments that, screening and assessments that medical providers can administer. And so we've been working with them on looking at their process and getting the providers all on the same page, because they weren't necessarily administering and following the same process. So we've done observational studies of their staff, and just from the time they take the client in the door to when they're finished assessing them, and again are helping them get where they need to be with that. And then we'll assess the success of their brief interventions and referral treatment, and hopefully it'll be positive, and we'll create a toolbox to then give to other clinics where they can implement this process. And other than that, these EPIs are just working on getting data use agreements with, like, what we have one for 1 year with Via Christi, but are looking at getting data use agreements with any institution or partner that we know that is has their hands in opioid and drug and alcohol use. Those can take a long time, so that's one of the reasons that we're dedicating one of these part-time positions to doing that, so we can have more of a regular influx of that data versus it taking months and months, or sometimes almost a year, to get that through legal systems. And then, like Tim had mentioned, we've started analyzing sheriff's data, WPD, and Via Christie's, and brought all the partners together, because I found that there were a lot of silos in Sedgwick County in regards to who was doing what, partners not knowing who had what grant, there being similar goals with partners but not working together because of not knowing. So some of this resulted from the sheriff bringing together his task force that Joan and I are part of, as well as many other community partners. And so I'm part of the sheriffs, and then we, as part of that, witnessed how many partners there were, and so brought them all to the table so that they could hear what funding sources first that everybody had, if they did have different funding sources, and what their separate goals were for their opioid. Most of it is focused on opioid work, but as far as grants, but the people at the table, partners, also realize that methamphetamines are the main issue in our community. So
let me ask you a question.
Go ahead.
Pardon my interruption.
No, go ahead.
Let's say hypothetically, I'm a woman, I come in for my yearly, and I say, I'm addicted to meth, I need to get off meth. Where can I go? What would your provider do for me?
Well, they would.
Like, I want to go to rehab right now, but I don't have any money.
Okay, so we would connect that person with SAC, the Substance Abuse Center of Kansas,
because hand them off.
They are the gatekeepers for state funding. So if someone is needing state-funded treatment or financial assistance with treatment, then they are going to be referred to SAC so that they can assess them and then see which treatment modality is best suited for them.
Okay. Thank you. That answers my question.
While you're there, I guess I'm a little. This was a grant.
Yes.
And now that's one thing that worries me on grants is that suddenly then they turn into a full-time position that we have to fund after we end up with a grant. And developing a lot of data might be okay if we're going to do something with it. But now we've had this grant. Have they developed data that we can do something with?
Well, this was an eight-month grant, and we've had the positions for about 4 or 5 months, and they've been extremely busy. Now, prior to getting these 2 positions, we had begun to look into opioid use in our community because of hearing how much of a problem. We started doing this at the beginning of 18, end of 17, just to see how much of an issue it was in our community because of hearing how much it is across the country. We just don't have the we don't have the resources or depth to continue this work to the level it needs to be. Our plan is to develop a front-facing, easily understood data set on the Sedgwick County website so that the community can see just where we are in regards to substance use, and working with the sheriff and the WPD to look at hotspots where, as far as arrests and drug use, and have a resource of all the possible resources of what people could access in our community. So there's different layers to what we want to do, and hopefully we'll be able to do. It's just going to be very difficult once these 2 part-time staff, once the grant ends.
What's this new person going to do that our drug coordinator is not doing?
Our drug coordinator, they aren't data analysts or epidemiologists have that background. It's a whole different skill set to be able to monitor and analyze and work with the partners to get that data and then do something with it. So they might be able to help. And they were both at the table when I pulled all the partners together a number of months ago. So they're really out coordinating, getting their feet wet, I think, on working with a lot of the partners and finding out who all is doing what as well. That's why I invited them. But so they aren't researchers or data analysts. So they can help connect people and get people to the table, see what they're doing, but don't have the data or the skills to my knowledge, to do anything with the data.
Okay. But if we add this position, we've got this position forever.
We can always use another epidemiologist.
I think you're going to have to rewrite this for me to say that, and get the opioid and make that minor, and methamphetamines major. because I just don't see that we're going the right direction. We've got to start solving a problem rather than keep collecting data saying we've got a problem. We already recognize we've got a problem.
I would agree, and I think the manager made a good point a little bit ago when he talked about funding that comes with strings attached to it. For whatever reason, there isn't a funding source directed towards addressing the methamphetamine issue in this country. The opioid issue caught the attention of the legislature, and it brought with it some funding, and so we've been able to receive some funding in this community to address the opioid issue. And as Adrian said, we've tried to expand that as much as we can and address methamphetamine as well. It's one of those problems, there just isn't a real good funding source for it, and so we're trying to make do with funding sources that we have, and we're approaching, in this particular instance, the commission for some additional funding so that we can continue to work on drug misuse, opioid, and methamphetamine.
Commissioner O'Donnell.
Thank you. And I would say from the past budgets, when some of these grant-funded positions have gone away, Adrian, you've worked with us to find spots to put those people, right, every time. So they're aware when they take one of these jobs that it is temporary, but you'll look for a new place to put them, correct?
Yes.
That was our discussion, I know, with the health educator, too. When that went away, you took that person and you put them somewhere else where they'd be good, and then the position came back, right?
We did hire a health educator. You approved a health educator, and we did add a health educator this year.
Mm-hmm. But two years ago it was approved, and then it went away, and it came back.
That was more the health analyst that was connected to the community health improvement plan and community health assessment.
But you understand what I'm saying?
Yes, absolutely. Yes.
Hey, I think we got a little work to do on this. Commissioner Meitzner?
Yep. Going to change subjects real quick?
Sure.
Or are we still? This is a
I don't care.
very worthwhile and healthy discussion for sure. I can't read your slide numbers here. 69. Thank you. I was going to say something about animal control because I just had a question, but then I didn't. And then the next slide shows $578,000 towards animal control. Tell me that is this the same animal control board that's combined at the city and county, or is this a separate animal control?
Two separate functions.
Oh my.
Sedgwick County has an animal control advisory board, an animal control staff, an animal control function that operates outside the city limits of Wichita. And then the city of Wichita has their own animal control function, staff, and advisory board.
Okay. It's traditionally been a rather emotional world.
It has been.
Yeah, really? They're the same? Well, in no disrespect, so this animal control budget and animal control board is all the dog bite stuff that's outside the city limits?
That is correct.
Okay. All right, thank you.
Where's that in our book?
544.
544. I was way off. Thank you.
Hey, we ready to go on to Station Package 2?
The other request for the health department is a request for an additional educator for sexually transmitted infections. If you look at state data, Sedgwick County is greatly exceeds the state averages for chlamydia, gonorrhea, syphilis, and we would like to be able to add a staff person that would address specifically those three issues in the community and continue to educate, particularly ages 18 to 24, 25, somewhere in that range, because that's where we're seeing the biggest spike in this disease spread. And so we'd like to add an additional position that would address education specifically on sexually transmitted infections to try and help slow that down.
Okay.
We've got investigators. This is pre-investigation and hopefully avoid investigation. So 2 decision packages, 148,420. The division summary is $76,474,825,000, and the bulk of that increase again is related to Comcare and some state funding that they're receiving. And the decision packages total $663,544, 9 positions, and there's 1 alternative reduction, $82,595.
Questions for Tim? Commissioner Howell.
I'm looking at those stats on pages 550 and 551. 2 of those looks like Kansas has changed more than the county, and 2 of those counties changed more than the state. All 4 of those cases are worse than they were in 2013, but I'm just looking at the amount of change. Has the state changed how they fund this, or have they been
Not to our knowledge, no.
comparison? Okay. Well, back in 2013, according to your notes here, we actually had this position funded in 2013. Okay. In 2 of your 4 measures, the state's worse than the county. Just letting you know, in terms of the percentage of growth. But all four measurements, of course, are worse today than they were in 13.
Nothing to be proud of.
I'm just wondering if this position actually is an effective position that will keep this from climbing or get back to 2013 numbers. I don't know.
I think that, again, the manager talked a little bit about evidence-based practices. Education is an evidence-based practice to stem the tide.
All right, thank you.
Could these numbers be increased because more people are coming forward or getting help, or is there a reason for that? I mean, like with, what's the AIDS group here in town? Positive Directions. You know, they're doing a lot more advertising. They're very prevalent. You know, now that they're, I mean, have you guys heard of them? I mean, just education about the services that are out there. I don't know.
That is a good question. We are focusing, as they are all through Kansas, on syphilis and HIV right now, not focusing on doing contacts with gonorrhea, because syphilis has been really up. So our resources are going directly to those 2 infections.
All right.
Thank you.
We have Glenda on today.
She is. We're going back to page 276 for corrections to finish up public safety.
Okay. Do we need a break before we continue?
Yes.
Take a 5-minute break. Okay.
Go.
Kate.
Just check your text about 79th Street. When's that going to be unblocked?
All right. We will get started with corrections, since we ran a little long and I didn't get finished the other day. So we're doing the Department of Corrections on page 275 in your book. The Department of Corrections, the mission is to provide a continuum of evidence-based correctional services in our community, which promotes public safety and accountability while supporting positive behavior change in an effort to reduce recidivism. So recidivism is kind of the core tenet of corrections, provide services to reduce recidivism in most of their programming. Adult service, juvenile service, and facilities are the three areas of corrections. And we will move to the next one. So in the 2020 budget request under property tax funds, we have pretrial service program. This diverts inmates away from the adult detention facility to their own homes under supervision with electronic monitoring. It's obviously it's a less costly alternative to incarceration. Clients served in calendar year 18 were 1,812 with a daily average population of 326. You can read the unit cost at $710 per unit, and the successful discharge rate was 57%. Adult Intensive Supervision Program. This is a state required program. It is a non-tax funded program, generally speaking. However, it is subsidized with county dollars. It protects the community by closely supervising felony offenders at appropriate levels. It's less costly to incarceration. They would potentially go back to prison. The client served was 2837 last year with an average daily population of 1474. And the percent of employed offenders is 83%. This is delivered by staff and in partnership with Comcare. And as we get into the budgeting, you'll see. But this program, again, it's a state required program. But we do subsidize this program with county dollars at a rate of $575,000 annually. DOC training program, consolidated department-wide staff training program to meet corrections requirements and standards, to ensure professional development of staff. And the number of trainings conducted in 2018 was 134, and we have 56 employees who serve as trainers to supplement the one person who runs the training program. Also in property tax funds is the adult work release program, which we stood up in corrections in 2016, January 16th of 2018, I'm sorry. Transferred from the sheriff's programming to corrections. The average daily population is 55. The unit cost per day is about $45, and the percent of successful discharges for the first year, fiscal year 18, was 55%. Property tax and non-property tax funding, DOC administration. So it's a mix of property tax dollars and grant dollars. Administration supports planning, budgeting, implementation, and monitoring of community-based offender programs for juvenile and adults. Provides centralized administrative services that enables the department to fulfill its mission. They operate 3 facilities, 14 programs, and the Corrections Department has collectively 332.75 FTE to run all of its programs. Property tax and non-property tax funds, Adult Residential Center. This also is a state-required program. It promotes public safety through close supervision of felony offenders in a residential setting. It's less costly than prison. Clients served last year were 305 with an average daily population of 57 at a cost of about $76 per unit. And the successful discharge rate was 74%. Adult residential is also one of those programs that is a state required program. It's funded partially by the state, but the county subsidizes at a rate of about $250,000 per year at this point. Property tax funding, Judge Rydell Boys and Girls Alternative Program. It provides evidence-based cognitive behavioral programming for moderate and high-risk juvenile offenders in Sedgwick County. Served 325 clients last year, 41 graduates from the program. Clients completing the curriculum hours to graduation was 83%, and the recidivism rate for a 12-month period was 10%. The juvenile services contracts, these are grant funded, and juvenile services awards an annual block grant to provide prevention and early intervention services. The target population is moderate to high risk for criminogenic factors, and in fiscal year 20 the service provision for case management under this block grant is being moved in-house. The Juvenile Intake and Assessment Center provides intake and assessment and referral services 24 hours a day, prevents youth from getting more deeply involved in the criminal justice system. There were 1,874 youth who moved through the through JIAC last year, and it is delivered by staff. Juvenile Field Services. This is a program housed down on Harry. Juvenile Intensive Supervision Program serves offenders on probation and at risk of entering state custody. Juvenile Case Management provides supervision for juveniles in the custody of KDOC, and Juvenile Conditional Release provides supervision for juveniles released from the state correctional facility. Juvenile Field Services continued. Juvenile Intensive Supervision Program served 284 clients last year with an average daily population of 127. The Case Management and Conditional Release Program served 232 with a daily average population of 105. Revenues collected through fees and fines and restitution was $14,746. The Evening Reporting Program is a grant-funded program. It provides evidence-based programming to youth to support rehabilitation, decreased recidivism, maintain accountability for behavior, and decreased use of secure detention. This is a program that was done in cooperation regionally using the state grant dollars. We are partnered with Butler, Cali, Elk, Greenwood, Harvey, McPherson, Sedgwick, and Sumner. 216 youth were served since May 1st of 18. Those other counties generally don't have sufficient population to be able to serve them in this type of programming, so they transport those kids into this program so that they can take advantage of it. There's 113 youth who completed the program requirements, and youth completed 870 hours of community service work. On Saturdays, they come in and do community service work and for several different entities who have decided to work with the Department of Corrections on this program. JDF, the Juvenile Detention Facility, is a 24-hour facility, secured facility for males and female offenders and alleged offenders awaiting court hearings. We had 724 clients in 2018. The average daily population is 53, and the unit cost is at just shy of $224 per day. Glenda notes that there have been no escapes and no suicides in the facility, and they routinely check with the clients, and 90% of the juveniles feel safe in that facility with the staff. Juvenile Residential Facility. The residential facility is a secure facility, meaning that people can't get in. It is not secure in the sense that the kids can't leave. It is a secure facility that provides less costly alternatives to secure detention. We had 283 kids served. The average daily population is 14. The average length of stay for those kids is about 22 days at a cost of $167.74 per unit cost. And 188 kids, 70%, successfully completed their placement there.
Before you go on to data, the budget request, does anybody have any questions on the different departments and the information you were provided? I got a couple of questions briefly. Last year, I seem to recall, but it's been a year, so I'm not sure if I said it then or not, but you list successful percentages on some of these, but not on all of them. And I thought last year we talked about giving us successful percentages on all of them.
You need to come to the microphone, Glenn.
Okay.
Hi, Glenda.
Good morning, Commissioners. Successful completions. So some of our programs are still new. When people are placed in probation, we don't usually consider that just successful. What we are looking for is the recidivism rate. So whether or not they successfully left the program and then recidivated after that. So some of the programs, the kids are just in and out. And we don't do like the kids that come into detention. There's no treatment for kids that go into detention. So there's no success in that factor. We consider being safe and no suicides.
Wouldn't recidivism be a success factor?
Not in detention. So recidivism is being collected in all of the other programs. And I have all the recidivism rates for 2018, except for work release, which is new, and they need another year before we can do any checks on them.
Okay. But when we go back to adult side,
Mm-hmm.
I'm talking about the whole thing.
Right.
Adult side, let me give you an example. I was just trying to figure out why that work release only got a 55% success rate, and the residential for the adults has 74%. I mean, it's 20% difference.
Sure. So work release, the clients are there for very short or long periods of time. There's not a program that's set for length of stay. So in other words, a client can be there for 30 days, or they can be out in 15 days, or they can be there for 3 months or 4 months. Again, work release just started, and so we're just calculating what their success rate is from last year. It's minimal. It's a different set of success rates, whereas adult res, it's actually a program. So the clients go in, they get intervention services, and they're there for a longer period of time until they successfully complete the program.
Okay. Well, I was just looking at some of these you had success rates on, and I'm trying to figure out what the difference is and why some of them are working better than others, and do we maintain
different measures of success really fit that. Like I said, what we're doing with recidivism, I'm calculating recidivism on all the programs except for the juvenile detention facility, which really isn't a treatment facility for kids. So we really don't expect that if they went to detention that they would actually come back being successful. They're not getting those kinds of services, where in all my other programs they go in and they get some intervention service.
Okay.
So recidivism rates are not listed on all of these slides. If you want those, we can have Linda.
I can provide those to you.
Some of them have success
Some of them
rates
have
and
them, and-
percentages, and others don't. So I was just trying to figure out why we don't list.
So, and also thinking about recidivism, in the adult world, we check recidivism at 1, 3, and 5 years. And in the juvenile world, we only check recidivism at 6, 12, and 18 months. So it's going to look different.
Okay. Well, we want everybody to be successful coming through
Sure.
the programs.
Absolutely.
Thank you.
Any additional
All right,
questions?
Rusty. You want to tell us about the numbers?
Sure. So the numbers in the general fund, the budget is down, and generally speaking, we're down about $2 million, a little less than $2 million in salaries. Grant funding is down a little bit, and totally we're down 8%. There's a $100,000 reduction related to the acquisition of the corrections database. For 2019, we had $100,000 in the budget to complete the implementation of that, so that $100,000 will go away. And then there was a $786,860 allocation in 19 to replace cameras in JDF. And so for 2019, or for 2020, that's $787,000 will also be reduced from the budget. Grant funding was down on the adult side, has historically been down about $100,000 each of the last 5 years on the adult side. And for 2020, I think right now they're indicating that it will be flat, but until they issue the award, we're not sure. So we do have 2 decision packages. The first one is not set in stone yet. We are still doing some analysis, but essentially over time there are increases in cost of doing business, increasing food costs. We entered into a contract on medical services that was a little higher than the previous contract that we had. But collectively, we believe that there's going to be a need for a few dollars to supplement that. We've put in here $80,000 as a marker. That could be a plus or minus number as we continue to analyze, and as we approach the manager's recommended budget, that'll be cleaned up, and we'll have a final answer for you on that. The second package relates to the DOC database that we purchased. At the time of that purchase, there was the initial purchase cost, and the commission was also informed that upon purchasing that software solution, that once it was implemented, there would be an annual maintenance and licensing fee that would go along with that at a rate of about $226,000 per year, $226,000 per year. So as we enter into 2020, implementation will be complete in 2019. The first year to pay the annual licensing and maintenance fee on that product will kick in 2020. While we were aware that that was going to occur, the way that we ask for that money is through a decision package in the 2019 budget. So this appears in the budget process now, asking for the monies to maintain and continue that software purchase going into 2020.
So will this be asked every year?
Yes.
In a decision package like this? Is this something that we have to do?
Well, in year one we have to. In subsequent years, if it's approved by the commission, then it would be the cost of doing business. I would assume that it would be carried from that year forward. Yeah.
So this year it's asked in a decision package, and then
it would be forecast in next year's budget.
Okay.
Or in 2021's budget, it would be forecast as part of their annual budget cost.
Okay.
So this replaced, if you recall, corrections for probably decades has had a piecemealed process for managing records that did not communicate across all the different programs, juvenile and adult. They had piecemealed pieces that just worked for each program, and this integrates all of that so that as they enter data from clients, if they recidivate and come back into the program, they've already got data on them. It's a collective database that will help them manage records much better across all programs.
Now, for $226,000, are they putting the data in, or are we putting the data in?
We are doing the data entry. They're standing up the program, but this is a web-based.
I'm just trying to figure out what they do for $226,000. I know we approved this a year ago, but now that $226,000 is a lot of money just to maintain a database.
This is an off-the-shelf database system, so it's designed for corrections. It's called eJournal, and we enter the information as the client that starts in the juvenile intake. As the youth comes in, then their information gets gathered, and it travels with them throughout their process through into juvenile detention. If they go into juvenile field services, eventually if they go into the adult program, it will follow them through the process. We are currently using this as well in our pretrial. Isn't it pretrial? So we use that. The district attorney's office also uses it. It's an integrated system. So it's off the shelf. We purchased it, and the maintenance cost is for them to maintain it and upgrade it each and every year for us. So we don't have to hire IT to go in and do that.
Okay, could IT do it?
No.
No.
That's what we had for the last 25, 30 years is we had a database that was built in Access, and it has slowly deteriorated. Now we're losing information, so that's why we needed to purchase this system.
All right, just sounds like a lot of money for somebody that's not doing anything but keeping a program up to date.
The maintenance will keep it up to date.
It keeps the program up to date.
Keeps the program up to date and allows us to add or take away information which we could never do before. So when the old system was built, we couldn't change anything in it anymore. It just was stuck. The new system will allow us to
The old
add.
system was just an access database that we cobbled together. But,
Yes.
I'm trying to figure out what this other company's doing out here in the cloud for
making money.
$226,000. They better have a lot of people working.
Any additional questions? So collectively, currently with the 2 decision packages is at 306, which is the database, and then, as I said, we're still doing the analysis on the medical services piece, and we will have a better calculation on that by the time we get to the manager's recommended budget.
Okay, Commissioner Howell has a question.
Thank you, Chairman. Just on the work release, how many people do you have that are in that facility getting services there at one time?
Well, we have an ADP of 55, but I think today they're at 70 clients. The capacity for that program is 100. And so as we build capacity, we also have to hire. And so there's a few vacancies there in corrections workers that we're wanting to put in place before we go all the way up to 100.
The folks that are in that facility, they're technically still considered incarcerated, but they're not on the sheriff's table. They're on your table, apparently.
Correct.
So as they transfer out of the jail to work release, they end up in your budget rather than his, correct?
Correct.
He doesn't count them as the 1,400 inmates. That's not counted.
No.
Okay. Is there a waiting list of people who are eligible to go to work release? We just don't have the resources to handle it?
I think there is actually a short waiting list. We have a specific capacity for women that we can't draw from. So once that's full, then it'll be a waiting list for females. Well,
I guess just my opinion is I would like to see us invest in that as much as possible. If there's a waiting list, I'd like to know that so that we can respond to that in our budget if necessary. But it didn't occur to me until just today that on his, he's not here, so I can't ask the question, but there was we anticipated some savings by doing the jail annex.
Mm-hmm.
And I don't see his budget went down what I expected it to go down. I don't know why that is, but I would think that by bringing those folks home, I was hoping to reinvest that money into treatment programs or education programs or whatever, mental health programs, something to help these folks become a little more effective as they transition back out of that incarceration back into the community. And same thing with this. If there's things we're not doing that we ought to be doing in terms of mental health or substance abuse or education programs to help these folks become more effective as they transition back into the private sector, I'd like to know what that is.
Well, I think when you think about the annex, the jail annex, that we moved all of the people from the annex to the work release program, and that gave him time to build the jail annex, and which I believe they're housing somewhere around 180
Correct.
Clients. Those are people that if they didn't have there, they would be having to be out of county.
Right.
And so I believe his numbers out of county are still high.
So we've had in the past, the number I remember is about 300 people that had been out of county, and right now because of the 180 at the jail annex, we probably are down to around 100, 120 out of county, and they're closer. We're using the closer locations rather than the further locations, so our savings is pretty good.
And I think your savings also is putting the work release clients into corrections where they're getting some services and employed, and we're doing some things differently and collecting more revenue actually through corrections.
Well, I guess I'd like to know if we need to know what the budget would be required to get that thing fully utilized. If we can get to 100 and get the folks out of the jail and into those types of programs, get them back to work and start paying restitution and things like that. That's a much more positive way to deal with these folks rather than let them sit in the jail. But
I think one of the barriers that we have right now, it's not the space, it's just making sure that we have the staff. It's hiring corrections officers.
Well, I guess my ask for you would be then to make sure the budget reflects what you need to do. If we're short people, but that's where our goal is.
Mm-hmm.
I think that money actually, again, it's a conservative position, fund this, it actually saves money. I believe that's true. So funding this, in my opinion, is certainly something I would be interested in doing because I think it actually is best for the community. And that money is, even though it may cost more in adult corrections, it may cost less money in adult detention, for example. So there's a shifting of dollars between budgets. And so I'm looking at the whole picture. You may be looking at your side of it, and Sheriff's looking at his side of it, but I'd like to look at it both sides at the same time. And if we can move people from the jail to work release, and we have staff there to make sure that happens, and we provide the services they need to get transitioned successfully into the community, that's a conservative, fiscal, conservative approach to this. And so I want to use that facility as much as possible. And if you're short-staffed, I want to know that.
Well, I think we're short-staffed because it's just hiring difficulties. We did something a little bit different this year. We actually turned one of our corrections officer positions into a recruiter to go out and actually recruit for jobs. And last year we hired 82 new corrections staff. That was the most we've ever hired over any year. So I think our recruiter is doing a fabulous job, but the fact is we have to still go out and sort of go to universities, go to different places, and recruit for those positions. We are in competition with the sheriff for jobs, and he's got a lot of vacancies. We have probably about 10 or 12 vacancies right now, where his is much higher than ours.
Well, this year he's also in one of his decision packages was for a recruiter as well. So it'd be nice to have a recruiter that can represent both agencies. I mean, that might be a way to do this a little more efficiently. But overall, I think the budget's really pretty great. But how can you explain an 8% reduction other than those few things you mentioned a minute ago? That doesn't add up to 8%. You're looking at about a $2 million reduction in budget. It's 8%, and you named off about $900,000 worth of packages from last year. Where's the other $1 million?
Those were held positions.
So they were?
No, they were funded but held. We didn't fill them, and some of those were grant.
Was that administratively held, or was it because you couldn't find the people, or?
Administratively held.
Okay. Are we planning to hold positions next year? Or?
Next year I won't have any positions to hold. Okay.
Yeah,
I have funded all the positions and filled all my my intensive supervision officers' positions.
I didn't realize we were making decisions to hold positions. I didn't know that had happened.
Well, some of the grant funds, if I have enough staff right now supervising clients, we do that. So for example, the juvenile population, it has decreased. Okay, so we didn't fund every position we could have because there wasn't a need to do that, and it just made good sense to not do that.
Thank you for the question. Thank you for the answers to my questions. I appreciate it.
Commissioner, on page 313 is the out-of-county housing budget for the sheriff. You can see for 2019 we reduced it $1.5 million.
Good.
For this change.
Thank you very much. That's a great answer.
All right, Rusty, tell me about crime prevention.
Okay, the Crime Prevention Fund. The Crime Prevention Fund just went out to RFP and came back to bid board. So they have awarded dollars to programs for 2020, or for the coming fiscal year. And I'll let them speak to the specific programs if you want to know about those. But essentially the budget is flat for the Crime Prevention Fund. The Crime Prevention Fund supports 2 secondary prevention programs for at-risk populations and 4 programs of services to reduce delinquency among those already involved in criminal conduct. Clients served in 18 were 979. Dr. Craig Moreland came and gave you all a brief on those programs fairly recently. And she's been working closely with corrections and with the service providers to ensure that where they had deficiencies, she's provided them with training to ensure that they're more effective in their programming. And like I said, we just completed an RFP process to fund programs for the next cycle. For the coming year, the budget is flat from what it was in 2019 at $582,383. I think the contracts that were approved for the coming year were just about $100,000 shy of that, with the intent to go out a second time to provide for another program that didn't get brought into that cycle. So they'll probably expend most of the rest of those dollars on the other program here in the near future.
And sometime, can you give us a list? Right now, you just said 2 programs and 4 programs. Give us a list of those programs. And also, it's almost $600,000, so we need to know successful.
Right.
And
That's what Dr. Craig came and presented on. They're the last group that completed the crime prevention dollars. This is a new RFP, so they'll start a new process. So I can send you out a list of who will be getting those awards. And she will be meeting with each one of the programs to make sure they're delivering the programs with fidelity. We do my staff do the auditing of those programs to make sure that they are on track and doing what they need to do. So I'll send you a list of those.
Okay. Well, I just need to know whether or not we're spending $600,000 and it's doing some good.
Yes.
Yeah, her recent briefing indicated that generally these service providers were providing the type of service that she and the program intend them to provide. And like I said, in areas where they had deficiencies, she had provided specific training to them and worked closely with them to overcome those deficiencies. And then coming into this next cycle, some of those same programs received awards with the understanding of what the expectations were based on trainings from the past and the requirements going forward in this RFP. So we'll get you the list of those who were just awarded, and we can give you a refresher on the information of the success of those programs from the last cycle.
Okay.
So, okay.
All right, commissioners, anybody have any questions before we take a break for lunch?
Will you send that to all of us? Mm-hmm. I just have one question. Who is responsible at what part of the budget is related to suicide prevention? Comcare? Do they have that broken down, like how much money they spend on suicide? Okay.
It's part of most of those activities happen in the crisis program budget.
Okay.
All right. Corrections, thanks for coming back. Sorry we had to keep you here twice. Very good. Well, I think we're coming back at what time? 1 o'clock.
Do you want to do 1:15?
Can we do 1:15 because we got a lunch? 1:15. All right. Thank you all.
Lacey agrees.